Hello, this is Dr. Ronald Wharton. I am an attending cardiologist at Montefiore Medical Center in the Bronx and assistant professor of medicine at the Albert Einstein College of Medicine in Bronx, New York. I thought I would share a case with you which I call the Atria Are Stunned, but you shouldn't be. So there is a patient in our CCU, or at least there was one day, who had had an atrial fibrillation catheter ablation the previous day, and the next morning he's short of breath and he has an echocardiogram, and does the echocardiogram give us enough information to explain why he is experiencing dyspnea, or do we need to do any further tests? That's what this case is all about. Here's a parasternal long axis. You can see that the overall LV systolic function is reduced. I can't tell you why. I don't know the patient personally. This could have been a tachycardia-induced myopathy. I'm not sure. You can see the aortic valve leaflets are maybe minimally thickened. The left atrium is enlarged, which is not surprising for somebody who had atrial fibrillation. The right ventricle grossly looks normal, even though you only see part of it in this image. And here we have color Doppler on the same image demonstrating nothing at all wrong with the aortic valve and nothing more than perhaps trace mitral regurgitation. This is a continuous wave Doppler in the right ventricle inflow view, RV inflow, looking at a tricuspid regurgitation signal. You can see that the peak velocity of the TR jet is only about 2.3 meters per second. The volume of TR would be considered either trace or mild, nothing more than that. It's not a very dense jet at all. And I want you to pay very close attention to this image. This is a pulse wave Doppler through the right ventricular outflow tract. And any time you look at a Doppler, you should always look at the timing of the curve, the velocities, and most importantly, the contour. You can learn a lot about what's going on from the shape of a waveform. So take a very good look at that. This is an apical four-chamber view. Again, you can see here that the left atrium is generous. There may be a trivial amount of mitral annular calcification. The mitral and tricuspid valves anatomically look okay. The RV function looks normal. The LV systolic function, as before, appears to be reduced. In the next slide, you see a pulsed wave Doppler through the mitral valve. Now, this patient underwent an atrial fibrillation ablation the day previously, so the rhythm has regularized. And I think on the 12-lead electrocardiogram, you could actually see small P waves. In this tracing, you don't. Certainly, you don't see any A waves in the pulse wave Dopplers through the mitral valve, suggesting any organized atrial systole quite yet. Again, they're only one day away from ablation. You can see the peak velocity of the E wave is almost 0.9 meters per second. The deceleration time of the flow is short at only 170 milliseconds. Here you can see a 2D image taken from the subcostal view of the inferior vena cava. Notice that the IVC is dilated and doesn't seem to change very much with respirations. So, a couple of questions. Why is this patient short of breath? Number one. And number two, is there pulmonary hypertension? Now you may say, well, look, the ventricle has poor systolic function. The deceleration time through the mitral valve is short. They're probably in heart failure. That's a very good educated guess. Can we do any more to quantify this? Can we prove it? Well, here's the pulmonic valve pulse wave Doppler. This is an image that I showed earlier, and I said, look at it carefully. You'll notice first that the acceleration time is short. I measured it to be 50 milliseconds. That's the time between the onset of flow and the peak of the flow. Remember that when there's significantly increased pulmonary vascular resistance, the flow through the RV starts later because the RV has to waste more time generating enough energy to open up the pulmonic valve. Therefore, ejection time, if you will, is sacrificed to isovolumic contraction time, which lengthens. The other thing that happens when the pulmonic vascular resistance is increased is that there's a reflected wave that partially shuts the pulmonic valve in mid-systole. Back when echo was just an M-mode science, this was referred to as the quote-unquote flying W, when they would M-mode the pulmonic valve, typically the right pulmonic valve leaflet, and the form that looked like a W would demonstrate partial closure of the pulmonic valve during systole, and that correlated with the presence of pulmonary hypertension. Similarly, when you look at the pulse Doppler flow through the pulmonic valve, you can see a little notch in each waveform. So the flow starts, and then it sort of comes down quickly and then restarts in the middle of systole. And you can see that in each of the 3 beats that I've provided here. The typical acceleration time through the pulmonic valve when the PA pressures are normal is probably closer to about 90 milliseconds. This I measured to be about 50. Might be a little off because the time scale is not designed for really, really extraordinary accuracy here. But visibly you can see that whether it's 50 milliseconds or 60, it's short. So this image alone suggests that there is in fact pulmonary hypertension. So remember, the TR jet only peaked at 2.3 meters per second, but the IVC was very dilated and really didn't change much. Therefore, the mean RA pressure might be in the vicinity of 20 millimeters of mercury. If we take 20 as a mean RA pressure, even with a TR jet velocity that peaks at 2.3 meters per second, we're already at a PA systolic pressure over 40. So there's some evidence that there is in fact pulmonary hypertension, despite the fact that the TR peaks at a velocity where most echocardiographers would probably ignore it. So is there anything else that can help us here? Well, remember, this patient had an atrial fibrillation catheter ablation the day previously. AFib ablations usually involve, perhaps always involve, a transeptal puncture, because the access is through the right side and then you have to get over to the pulmonary veins. So it means you have to go through the interatrial septum. Can we take advantage of that? Well, in this case we could. So what I'm showing now is a 2D image with color in the subcostal through the interatrial septum, and you can see that that transeptal puncture has still left its mark, and that there is still flow going from the LA into the RA. The Doppler of that flow, and now this is continuous wave Doppler, demonstrates velocities that are anywhere between almost 1.5 and almost 2.8 meters per second. So obviously during the cardiac cycle, where the pressures in all of the chambers are constantly changing, you're going to have differing gradients between the LA and the RA. But remember, in the next slide, the RA pressure is at least 20 millimeters of mercury. And if you looked at the previous Doppler, the gradient between the LA and the RA went as high as 30 millimeters of mercury, because the peak velocity of that transeptal jet was 2.8 meters per second. Therefore, we have proven that this patient is short of breath because the left atrial pressure is too high. So if you could infer the presence of congestive heart failure from the image of the ventricle itself and the poor systolic function, and if you could infer it from the deceleration time of the E waves and the pulse wave Dopplers of the mitral valve, you've now proven it using a combination of the IVC morphology and the velocities of the flow from the LA to the RA. And this patient responded, as you would expect, to treatment with diuretics. Take-home message is that just because the TR velocity may not be as high as you would expect it to be if a patient has pulmonary hypertension, doesn't mean it's not there. And we all know in echocardiography that echo can never overestimate a velocity. We can only underestimate it, especially if a jet is very eccentric and the beam is not parallel to the flow. But also in this case, the RA pressure is so high that the velocity of 2.3 was enough to give you significant pulmonary hypertension, and valuable data can always be obtained by looking carefully at the flow through the pulmonic valve, which is a valve which regrettably I think gets neglected all too often unless you're practicing adult congenital heart disease. In any case, I enjoyed this. I hope you did. This is Ronald Wharton from the Bronx on theheart.org at Medscape. Thank you for listening.